Is it on now? Because it's blank, not blue.
I went from the main machine.
Okay. No, we are on. Okay. Good afternoon, everyone, and welcome to today's HIV ECHO program, on which we'll be discussing differentiated ART service delivery and appointment scheduling. To help us discuss this topic today is Professor Henry Fomundam. Professor, welcome.
Thank you very much.
I got that correct.
Very correct, very correct.
Thank you very much. With us in the studio are a number of our guests from Howard. That we have a lot of individuals who have joined today, which will be very difficult for me to mention all of them. And a number of facilities like capacity. In the whole class of the HIV nurse practitioner class of 2019 who have joined us as well. So before we go in today's topic, we shall go into the recap of last week's session. Mr. Davis.
Okay, so good afternoon once again. So just a summary of what we had for last week when we looked at the topic addressing missed opportunities in the national PMTCT cascade by optimizing cohort monitoring. So if we remember very well, at the end of that session, we're expected to how to eliminate leaks in the maternal PMTCT cascade and how to understand steps to eliminate leaks along the HIV-exposed infant cascade, and understanding HIV-exposed infant cohort monitoring as a tool for monitoring HEI, retention by cohort, and determining actual MTCT rates. So several points were raised, and in the interest of time, we may not go through all of them, but it is good to note that some of the points that came out are as follows. Testing at ANC1 is good, but needs to improve initiations for all positives that are not yet on treatment at every entry point. And then PMTCT EID, that's just a brief definition, number of infants born to HIV positive women who received a first virologic HIV test or sample collected by 12 months of age. And in this case, there is a reporting of the first sample that is collected for each HEI. And then there's a need to triangulate expected deliveries for positive women and the number of HIV-exposed infants in the integrated MCH register. And that is all to ensure that all HEIs are tracked, if not captured, in the cohort register. And then thirdly, all HEIs should be tracked as cohorts to ensure that all have a documented final outcome. And that is conducting active tracking of HEIs with missed appointments. So that is very cardinal. And last but not the least, concerned longitudinal tracking, which allows for measurement of real MTCT rates. These and many other things were discussed, but we thought this would be a good point at what we had for last week. Thank you.
Thank you very much, Mr. Kampamba, for that recap of last week's session. Before Professor comes in, I would really love to remind everyone to please minimize the movements and ensure that we keep to the rules so that we go into our session. Professor.
Well, thank you very much, Dr. Francis. And on behalf of Howard University and the HBCU,
Yes, yeah.
Can go on?
Yes.
Okay. On behalf of Howard University and the HBCU Global Health Consortium, thanking the organizers for inviting us to be able to come to this very illustrious platform to share what we do in Lusaka. Howard University is part of a consortium, and I'm sure a lot of people have heard of Howard University is the oldest Black university in the US, and has been collaborating with Africa for a very long time. So we're very privileged and very happy to be working alongside some very hardworking healthcare professionals here in Lusaka. While we're waiting for the computer glitches to be rectified, Howard University we've been in the country since 2017, and our area of focus has been differentiated service delivery, which our pilot site was Matero Hospital, and we are now currently in the in Kanyama, Chawama, and Chilente. And so some of the examples that I'm going to be using, or the data, is going to be based on what we have at Matero Hospital, because it was our first site, it was the pilot site, so it's maturing right now. So I'll use it for illustrative purposes, but whatever I say, it could be extrapolated to any facility in the country, and that's our hope, that what we've been able to demonstrate with a lot of visitors that have visited Matero Hospital is purposely to benefit from what we've been able to establish with very good results, and we have the ARG in charge from Matero here with us today. Next slide. So I will just go over the session objectives, which again, in general, and I'm sure everybody around the country understands what differentiated service delivery is, or differentiated care, which is the way WHO calls it. And I will talk about ART DSD Plus for stable clients, and then I will discuss the kind of expected outputs from this kind of intervention, which is quality assurance for the patient care that we're carrying out in the country. We want to describe how you operationalize it, and discuss how to set up an appropriate scheduling system. Now, scheduling an appointment system is very critical, although all the different components are quite critical for you to be able to receive the optimal results. And then we want to describe how you be able to monitor these results. So I'm going to probably turn over to Dr. Francis, because I've been asked that we should have a brain teaser to be able to keep everybody awake. And so Dr. Francis is going to lead that component.
Okay. So we'll now try to do some core questions. Chatonda, am I launching from here? Yeah. So the first core question is as follows. Differentiated service delivery only applies to ART use, which is dispensing, medication pickup, and adherence. Is it true or false? I can see a number are voting. We'll give 10 more seconds. Okay, about half of us have polled. We can look at the second poll question, which is as follows. 6 months scripting for patient brings about tremendous benefit in reducing patient visits to the clinics and hospitals, but also help to decongest the facilities. It, however, has an inherent challenge, which may include, you may select the incorrect answer. Storage of medication at home by the client. B, increase in viral load suppression. C, lapse in adherence without knowledge of the healthcare worker. D, new onset of a side effect may be missed. So this, you are encouraged to pick the incorrect answer, not the correct answer. So which one is incorrect? It's quite interesting. Okay, thank you very much for those who have participated. The next poll question. End it, please. It's not ending.
You can close it. Close it. Yeah.
Okay, so the next poll question is proactive appointment scheduling in fast-track DST models involves A, seeing clients on first-come, first-served basis. B, clients who are early for an appointment are sent away. C, appointments are scheduled by time and date. So proactive appointment scheduling in fast-track DST model involves seeing clients on the first-come, first-served basis. B, clients who are early for an appointment are sent away. C, appointments are scheduled by time and date. Okay, so we will go to the last poll question, which is, when should you report a suspected adverse drug reaction? When should you report a suspected adverse drug reaction? A, when it is serious. B, if it occurs more than once. C, when you are sure it is a result of the drug the patient is taking. D, when you fail to manage it. E, none of the above. So when do you report a suspected adverse drug reaction? A, when it's serious. B, if it occurs more than once. C, when you are sure it is the result of the drug the patient is taking. D, when you fail to manage it. And E, none of the above. Only about 30% have voted. Okay, so we shall revisit these 4 questions again at the end. Professor.
Thank you very much. Okay, so I just wanted to talk about what is differentiated care or differentiated service delivery, and I think everybody in all the sites and all the countrywide, it's approaching this, and it is a terminology that actually means that you're differentiating the patients based on particular parameters. However, the most important thing to keep in mind is that it must reflect the preferences and expectations of the patient, and at the same time, also reducing the unnecessary burdens that we have on the health system. In other words, you're differentiating based on specific parameters. So it could be in HIV prevention, treatment, care, and support. ART is just very popular because that's what people are using right now. This was totally embraced by the Ministry of Health in Zambia because of the fact that it's going to lessen the burden of care for both the patients and the providers, and also allow the health system to focus resources on just patients that are most in need. And again, because we're moving towards the 90-90 target or 95-95 targets for 2030. Next slide. And so what I've just described to you is how it's a very client-centered service, and it must be focusing to improve the health system efficiency. And if you do all of that properly, you would see that it's going to improve the patient outcome. It's going to improve the patient satisfaction and the quality of life of the patient. It does improve the confidence in the healthcare system. And throughout this continent, there are a number of patients in a number of countries that don't feel very confident about their healthcare system. But when you decongest and do the differentiated service delivery, they begin to feel very confident about it. And you want to improve the hospital staff, the clinical staff satisfaction, because they're not overwhelmed. And again, moving towards our 90-90 or 95-95 targets. Next slide. So the key models that we have for differentiated ART delivery, they're facility-based and community-based. The model that Howard University is implementing in all the 4 facilities is facility-based with individual models, but also the fact that within the facility we're doing down referrals. And again, because of the dynamism of HIV management in the country, that has been modified a little bit, and I'm going to talk about it in subsequent slides. Next slide. So the overall aim of the ART DSD Plus is that we look at the quality of ART care. We're also involved in linkage to care. It's also involved in retention. And so all of this, we're going to discuss it. These are the high powered issues to ensure that the patient is getting proper care and we're meeting the target. So we'll be talking about it. If you do that properly, you should be able to meet up with decongest the facility. So with the Howard University model, which we call it DSD Plus, because of the fact that the plus component comes up because it is patient-centered, but very comprehensive. So for the Howard model, the DSD Plus works at the level of HIV prevention because we distribute the condoms, as most people would do, but we also make sure that through our index testing, the discordant couples that we have, we're referring them for assessment for if the patient should be initiated on PrEP. And of course, in terms of making sure that through the index testing, people are diagnosed properly and they're tested and diagnosed. And of course, the second 90 or 95, making sure that there's the fast track, which is what we apply in all our facilities. And then we're doing down referral to make sure that patients who live far away from their communities are able to pick up their medications from within a walking distance if possible. And then the last one is being virally suppressed. Here we've introduced a number of programs in our settings, particularly that of monitoring adverse drug reactions, besides proper counseling, which we train our staff to be able to do that. In the pharmacovigilance program, we're able to monitor very aggressively any adverse drug reactions that the patient may have. We do documentation, we send it to ZAMRA, we discuss the cases, and we're documenting, especially with the switch from TLE to TLD, we're very aggressive in monitoring. And we have, in fact, picked up new signals for TLD, which have not been widely reported. We're seeing a couple of polyurias, and so we think we're gonna look at those signals in our 4 facilities and see if that's something that within the level of ZAMRA and within the level of the team that is looking at guidelines, to be able to report this to them, to say this is a signal that through the DSD program or DSD Plus program that we're running, we're picking up new adverse drug reactions which could be of concern. And we can discuss that at a later time, because if the insomnia that is heavily reported, we don't quite see it in our programs, but we're seeing actually a number of patients reporting drowsiness. So these are the kind of things that we do in the DSD Plus program. It's very robust. And the fact that we have our clinics open on Saturdays to make sure that the men are coming. And 80% of the people who come to our Saturday clinics are actually men, which is quite a plus for the program, because throughout this continent, men are lagging behind. And those are some of the challenges that we have. And then linkage to care, which we spoke about. Our linkage to care comes through the process that at Matero, for example, the number of patients that reviewing the patient records, we see that they had a higher CD4 count when they were diagnosed maybe 2 years ago and they were asked to go home. So we're beginning to call them and bring them back, and we'll see some of the data that we have, because nobody has been, I mean, it's difficult to keep in touch with them. So that's what, through the DSD Plus, we're making sure that those patients are linked to care. Next slide. So all of what I've been said could be described in this model, and this is our flow chart. You may not be able to see it clearly, but our starting point is the patients that are HIV positive, is the cohort that is positive, and from that cohort that is positive, we're able to select based on the national criteria who are the stable patients that we can enroll into a DSD program. And again, it's based on making sure that the patient have a good history of adherence, making sure that their viral load is below 1,000, and making sure that they've been on treatment for at least 12 months and more, so that we can have up to viral loads and able to make that decision. No opportunistic infections, no adverse drug reactions. And again, that's a dicey thing, because adverse drug reactions, from the definition of WHO, it could be nausea, vomiting, and all of that. But that's where clinical management and patient-centeredness comes into play, because if a patient is having just nausea and vomiting that is going to go away, we'll be able to enroll them into a DSD program, understanding that that's a very acute situation that goes away. And so based on that, when we meet that criteria, and then you're selected either to be on a fast track or you're selected to be now transfer out. We used to call it down referral, but because those clinics now have become full-fledged ART clinics, we're going to keep in touch with them, and the mentoring and would continue in these facilities. Otherwise, we were referring patients so that they can pick up their medication closer to home. And of course, those that are unstable, this is a dynamic situation. We keep reassessing them and reevaluating them to make sure that if they become stable, then they're transferred to a DSD program. And if we have a patient in the DSD program that for some reason comes up with an opportunistic infection, then we'll do the reverse. Next slide. So this slide is just describing, we're giving you the example of Matero, and the reason why I chose only Matero is because it was our pilot site, and it's maturing and in a very nice way, and that has been the model, and a number of visitors have been there. But the TX curve there is about 13,000, and we have about 9,000 patients that were virally suppressed, and that number has changed. We're probably about 8,500 of them that are enrolled in the DSD, and we had down referred a number of them, perhaps about 800, 900 of them now. So majority of our patients at that facility are actually on the fast track, and they're warming up and beginning to accept. So now we're going to get to the point where we do a transfer out, so that we'll be able to tell them that to go to the nearest facility. If it's a full transfer out, and then we'll continue to work with those facilities. Next slide. And so this is just giving you some of the data that how successful we had been so far. When we started at the facility, the waiting time for clinical assessment was about 6 hours. And the waiting time for refill and pickup of medication, or the turnaround time, was about 4 hours. When we introduced the DSD fast track model, the waiting time came down for clinical assessment, came down to 3 hours, and for the turnaround time for pickup of medications was reduced to 20 minutes. So from 4 hours to 20 minutes. And then when we now have, because of the dynamism, we now have a DSD clinic, which means it's a one-stop shop. When we introduce that aspect of it, then in the normal clinic, we're able to have our turnaround time drop to 3, and in the dedicated DSD, it's now 1.5. Now you can see that the time for picking up your medication, the turnaround time hasn't changed a lot, because we've given you the upper limit, which is 20 minutes. Sometimes it takes about 10 minutes. The reason is because we want to make sure that our frontline staff are counseling the patients properly, and that's something that we do. Make sure that before the patients go, they're properly counseled on adherence and other issues, and that our community health workers are going to be getting in touch with them for a number of questions and support services. Next slide. So this slide that you see is actually describing people who missed their doses for less than 7 days. I can't see the number from here very well, but there was 200 odd people that missed their doses when we just 242 that missed their doses when we just started in January 2018, and in May of 2018 it came down to 100. This is when we had already kicked in. Our community health workers were reminding the patients to pick up their medications and reminding them for their exact time when they needed to come. And then in December 2018 it dropped down to 16, because we've been making sure that we're very proactive on that, and recently it's dropped down to 5. And we want to keep it less than 5. And so we're still working hard on that aspect. Next slide. So on this slide, it's actually just describing what our value-added services are in terms of patient management, in terms of treatment quality assurance for the medication. Now, if you look at patient management, for example, we make sure that in our facilities we're supporting and making sure that everybody has a smart card. We ensure that the smart card is updated all the times, because a number of them come, either the cards are missing or some of the information has not been updated. And one of the things that we pride ourselves with is that we actually are embarking on a prevention of loss to follow up. We think it's very cost effective not to start tracing patients, but if we can prevent the loss to follow up, meaning we call you to remind you about your pickup date. We also, as soon as you don't show up on that same day, our community health workers begin to call you and they're very aggressive, but politely aggressive, to make sure that you'll be able to come back. And we've had very high success rate of about 92%. And then our linkage to care, which I described, and again, this data is a little bit old, if updated, about 326 patients that we had at that time that had high CD4 count and were not coming back to care. We're able to identify them. We called them, and 73% of them were able to come back. Some of them came back to Matero. Some of them went back to other facilities that were closer to them. But that's an active program that we're doing. And then the extended hours that I described, and the fact that we're doing referral for cervical cancer, we're doing TPT in our DSD fast line clinic. And then with the treatment, again, we've talked about some of the pharmacovigilance activities that we have in place. We're making sure that we're also calling patients when they have a laboratory appointment. Our community health workers are there to remind them so that they can have their viral loads done. And based on all of this, at 6 months when we started the program, we had about 98% retention, because we're making sure that the patients that are under our care for fast track and down referral, all of them were coming back into care. And for the HIV prevention component, again, we spoke about the condoms that we're giving and the index testing and the referring of discordant couples for an assessment for PrEP. Next slide. Well, so how do we get all of this is what this slide is talking about. How do you set up yourself to be able to get all of this going? Next slide. Of course, the human capacity Otherwise, by the time you see them, it will be too late. And the adverse drug reactions, there may be a new onset of adverse drug reaction that has started. If you miss all of that, then you may have a situation where after 6 months, the patient shows up and tells you that I had stopped taking the medication since 3 months ago. And so we don't want that. And so that's, for us at Howard University DSD Plus, we're putting a program where we train our community health workers to be able to follow these patients on every 2 months. Talking about in terms of how you schedule the patients, in terms of how you, lack of a dedicated fast track. And when we just got to Matero, everybody was lumping into the same area. That was just a recipe for congestion. Next slide. So this is very critical. This is the appointment system and scheduling that I was supposed to talk about. And what we do is that we give appointments to patients based on the date, based on the time. And to give them incentive, we give them a block that you need to be able to show up. And this is an example that gives 1 hour, 30 minutes, but our blocks are usually 30 minutes blocks that we give them. And in order to make them comply, I'm skipping around, in order to make them comply, when patients come, our community health workers have been able to been trained to give them health talks where they talk about time management and keeping of time. Reason being that if you come exactly the day that you're supposed to come and on time, you'll be served, you'll be there just for a few minutes. So that's the incentive. We call them the green patient. But if you come ahead of time, which is not really your schedule, you did well, but not exactly, because you can also begin to cause congestion. So we call you the yellow patient. If you miss it completely, you come a day or two after your appointment, you're the red patient. We have to finish everybody, so you will have to wait. So in that case, the incentive is on green. And so most patients are responding to that. Coming to the end soon. So this is just the indicators that we have. We have a number of indicators, how you monitor the patient, again, discordant couples, index testing. We have a number of parameters that we capture on just to make sure that we are on the right track. Next slide. Now, the right track for us is quarterly monitoring of our program to make sure that we have things like waiting time, we have things like on-time ARVs pickup, and patients that we're referring, make sure that they get to their destinations if they're patients that are coming from the community. And then lastly, my last slide, just to summarize. Well, again, thank you very much. So just to summarize some of the things that I've been talking about is that DSD is diverse and multidisciplinary. It has to be multidisciplinary. That's why I have a frontline team that is sitting here today, and we'll be able to, we also do differentiated service, differentiated answering of the questions. So any questions that you would have, we're going to differentiate it, and the frontline team would have to answer that. We have a functional, if you have a functional DSD, which we've spoken about it, you would actually see your patients smiling more. And most people have not seen their patients smile for a long time. If they can come to the hospital, pick up their medication, and off they are gone, even the men that have not been coming, they'll be able to come. It's because some of them are at work, they can actually take a break and come and pick up their medication. And then the proactive scheduling that we've spoken about. And of course, I cannot emphasize enough to say, do not just give 6 months worth of medication to the patient and allow them. That would not be proper DSD, and because there are a number of problems that are going to occur if you do that. So we have to keep in touch with them. We have to keep monitoring. I think that's the very last slide. Thank you very much.
Thank you very much. And we wish to apologize. I think there are about 2 slides when we were offline, and I think it was due to the internet hiccups. However, I think for those who did not get what was, you can actually pose a question, and I think we'll be able to revise that. So we will now go back to the poll questions, and we try to see if we can go through the same and together with the answers now. So I will be sharing the poll questions once again, and then let's see how much we have learned for today. So the first poll question is as projected. Differentiated service delivery only applies to ART use, that is dispensing, medication pickup, and adherence. True or false? So the poll is on. Okay, so thank you very much. Prof, any comment?
Well, about the answer, right?
Yes.
The answer is definitely false, because I spoke about the fact that differentiated service delivery is actually a global terminology, which actually means you're differentiating your patients based on specific parameters. So you can have it for prevention, treatment, care, and support. So it's not only for ART. ART just has to be the popular one because, of course, in every HIV program, we're spending highest on the medication use, and that's where the issues of quality come about. Otherwise, with differentiated service delivery, you can see it even prevention, care, and support.
Yes, so thank you very much. We'll go to our second poll question. Okay, so this one is 6-month scripting for patient brings about tremendous benefit in reducing patient visits to the clinics and hospitals, but also help to decongest facilities. It, however, has an inherent challenges which may include, so here we are supposed to select the correct answer. So which one is incorrect about 6-month scripting for patients? Kindly go for the incorrect choice. Okay, any comment again?
Well, the comment there is that if you do 6 months scripting, definitely you want to make sure that there's viral load uptake. So the incorrect one, there will be the viral load uptake. The other ones are the ones that they say we're talking about challenges, right? So the challenge is going to be storage of medication. The challenge is going to be the adherence that we spoke about. The challenge is going to be the adverse drug reaction. So it's a trick question which makes you to think a little bit deeper. Yeah.
All right, thank you very much. The third one is proactive appointment scheduling in fast-track DST models involves A, seeing clients on first-come, first-served basis, B, clients who are early for their appointment are sent away, and C, appointments are scheduled by time and date. One goes for you. There's always that. Okay, thank you very much. So the majority have gone for C. Okay. About 89% of the participants.
Is there anybody that went for anything different?
Yes, about 7% went for A and 5% went for B.
They need to call me. Now, first come, first serve was the old method. That was the reason why we had so much congestion in the facilities, and we don't do that. And as compassionate healthcare workers that I've seen here in Zambia and Lusaka, you will not send a patient back, right? So you would just, in our context, we'll put them either on a yellow or red line, which means you will have to wait because you came on a wrong day. So the answer is C, very correct.
Thank you very much. So we go to our last question. When should you report a suspected adverse drug reaction? A, when it's serious. B, if it occurs more than once. C, when you are sure it is a result of the drug the patient is taking. And D, when you fail to manage it. E, none of the above. Bring those answers, let them keep on coming. Sorry? There is. Okay, so thank you very much. Prof, the majority going for C.
Wow.
Then we still have about 3% going for A. And 6% going for B.
Okay.
0% going for D and E.
Which is none of the above.
Yeah.
Okay. Now that tells me a major problem. In the WHO database, which they report all adverse drug reactions globally, Africa is the worst. And of African countries, they don't have pharmacovigilance processes in place. And that's the reason why you chose the answer that you chose. The answer is actually none of the above, because in a proper pharmacovigilance program, you have to report any adverse drug reactions. That's why at Matero, we're able to tell you that people that have been transferred from TLE to TLG, quite a good number of them are reporting polyuria. If you were waiting to do A to D, then you will not pick it up. And so in a normal pharmacovigilance, you should report any adverse drug reaction untoward reaction. Secondly, the doctors and pharmacists are very poor in reporting adverse drug reactions. If you tell them to make a decision on whether it's caused by the drug or not, then you're actually asking them not to report. So in global pharmacovigilance, you tell them to report any untoward reaction, whether it is caused by the drug or not. The pharmacovigilance expert team would then make a decision on what they call causality to say, is it the drug that is causing or is the disease process? So that's something that we need to improve, because people take it for granted. A lot of people stop taking their medications because of side effects. They may not even tell you, the healthcare worker. If I'm going to take medicine and I'll be vomiting every day at work, trust me, even at this level, I'll stop taking it. And I may not tell my doctor if you're Dr. Francis. So that is a very important aspect, that in pharmacovigilance, we have to set it up. And that's in all our facilities. We're now beginning to collect the data and discuss some of the cases. We're still moving to get ZAMRA involved so that we can set it the way a proper pharmacovigilance should run. So that's very important, that people should not overlook that. And then we have to pick up new signals. We cannot wait for WHO or the US to say, look, this drug has a problem, and then Africa says no. Because some of the drugs, because of our genetic factors, is gonna occur not only in our population. So we cannot wait for any foreign organization to be able to do that for us. So on that note, which you could hear me talk passionately about it, because that's what I do a lot of times.
So report any side effect, even when you think it's because of that drug. You might just discover a new side effect. So please, you are all encouraged to report any side effects.
Part of the answer was in the question itself.
Yes.
Yes.
Any suspected adverse.
Exactly.
That's not sure.
Yes. Yes.
Exactly. Thank you very much. So now, are we open for question and answer session? I understand that there's a question which is coming from memory, and I think we'll just ask you to hold on, because that is actually the question for the day from the didactic. Chilenje is asking, how can we replicate the results and lessons learned in terms of DST in maternal and child health? Prof.
Well, I think we want to make sure that we're having integrated services. That's one of the things that I'm also thinking about, not only in maternal and child health. In the future, we shall begin to integrate a couple of other components. Here, it's the inception phase, so we're doing it for HIV/AIDS, but this is something that we can begin to integrate other services and then restructure it. So it's a very valid question. So we don't run fractionated things, but because of the fact that it's the burden of HIV/AIDS, so we're starting with that. Eventually, when it matures, I think we should begin to make sure that we're adding other programs to it. I think that's a good question.
What about color coding? Should we apply to pediatric patients? I think there's a question from Leonard.
I'll ask the color coding expert, Tamara, to be able to answer that. And I'm not very good with colors. Sometimes I know.
So Tamara, you can give us any thoughts about color coding for pediatric patients?
Oh yes, but in my observation, I've seen that most pediatric days are not as busy as the adult days, right? But if you want them spending very little time in the facility, then it's something that you can introduce, but it begins with giving them an appointment by date and time. Then you can apply the color coding.
Okay.
So of course, as Ministry of Health, we encourage people to have separate pediatric clinics from the adults.
Okay, thank you very much for those thoughts, Dr. Sombo and Tamara. I will allow one more question, and I think if you can use the hand from the platform, that would be great. Any questions before we go to the case presentation, which is going to come from Petauke?
This was a comment about the work that Howard is doing at Natero. They've seen a lot of improvement in linkage and retention. I don't know, the comment has disappeared. Yes, I think from Patrick at Lusaka Province.
Okay, the one I have here is talking about internet issues. Yeah, so please, I think we can now go to
Sorry, just a question. there was a lot of nuance that you mentioned, and it's very nice to see DSD finally come into practice in Zambia and such great results. 98% retention is amazing, because the whole country, what we are struggling with now is retention. We are doing well in terms of starting people on ART, but our cohorts are not increasing much, meaning we are losing the patients we are starting on ART. We start me today, and I'm lost. I wanted to just get it a bit clear, because you use the term DSD plus. What's the plus that makes the DSD at mature work? What's that plus?
Right. So the plus, and these frontline people will be able to say, the plus is the fact that if you do just DSD, somebody will do maybe the community, the CAC, or somebody will just do the fast track. We're making sure that we're doing linkage to care, which is not a traditional DSD activity for most people. We're making sure that we do prevention of loss to follow-up, which people were always waiting for the definition of loss to follow-up, which is 30 days. I'm glad to see that the memo from you guys from the Ministry of Health in April is saying same-day monitoring. We have introduced pharmacovigilance because we know that a lot of people stop taking their medication because of that. We're involved in prevention. That's not a normal DSD activity for most people. And so we go through the 90-90-90 cascade plus linkage to care and prevention. So all of that makes it what we call the DSD plus. And then within that, we're going to be, there are a number of activities. When you say pharmacovigilance, that's a whole activity that we carry on. Yeah.
Okay, so I think last question before Tinta comes in with a case. There's a question saying, how was decongestion measured?
We have the data, and let me have Tamara, who wants to get that? You want to do it? The frontline people. How was decongestion measured? Go ahead.
So one of the things that we use to measure decongestion is the waiting time. Yeah. So some people would call it the turnaround time. This is the time that the client spends in the facility, from the point of registration to the point of where they're collecting their medication. And you saw that initially, for DSD, a client would wait 6 hours from the point they register to the point of pharmacy. But this was reduced to 2 hours in the main ART. So when a client comes in, they'll do their labs, they'll see the clinician and pharmacy, but only spend 2 hours. Okay? If it's a refill visit, then the client spends only 20 minutes. So this has been calculated scientifically. And what we do is we have cards where clients clock in, and as they leave the pharmacy, they clock out using the cards. And these cards remain behind with the pharmacy people, and they indicate the time that they are leaving the facility. So we measure decongestion using the time cards.
What about the cost involved in doing all this, especially that you're mentioning cards and everything? How much did you actually spend to bring up the project?
Coming from an academic institution where we're very tied with money and things like that, the cards was the cheapest thing. Dr. Francis, you've asked for the cheapest one.
Are they the same one like when you go to these service providers, MTN?
No. These are just manual cards that we made just to make it, we printed them ourselves, just to make it nice for the patients and they're able to clock in. And it's not a sophisticated electronic system. We haven't got into that. It's a manual cards that we just printed. Yeah, paper. That's
so
it.
It's as cheap as paper. Guys.
Very cheap. Yes.
Thank you very much. So, there's another hand.
The 2 hours and the 6 hours, is it median or it's mean?
So that's for the 6 hours. That was our baseline, and it was the average time spent.
Average, mode, median, or mean?
Mean.
Yeah. What's the mean?
That's the mean.
Okay, so thank you very much. We now call upon Mutinta Shikapaya, who is ART nurse at Petauke District Hospital. Are you able to see the slides, Mutinta?
Oh, mazabuka. Material man. Napa not available.
Mutinta. Sorry? Petauke. Meanwhile, as we are waiting for Mutinta to get ready, Tamara, how does the provider efficiency, affect this model? Do you really have to get super efficient staff, or just the normal pace that people wake up?
The material in charge should be able to answer that, but I think it takes people that are dedicated. So if the attitude is the wrong attitude, then they won't be able to implement something like this. So people have to be committed, because what decongestion does is it allows for more time for interaction between the client and the provider. Okay, so I think providers have to be efficient and they have to be committed to work too, but the in-charge can take it up.
Go ahead. Okay. So, okay, Mtinta, are you ready?
Yes, I'm ready.
Okay, please, let's go ahead with the case presentation.
Okay. I'm presenting a case from Souke District Hospital. We have a male, 42, who was diagnosed HIV positive on the 28th of April, 2017. He's a farmer, married to one woman who is HIV negative. He's a father of 2 children who are both HIV negative. He was diagnosed and treated for TB on 28th April 2017. That led to his HIV diagnosis. He started ART on 26th May 2017, and he was put on TDF 3TC EFB. Then later on, he was transitioned to TLD on 22nd March 2019. The latest visit on physical examination, BP was 111 5 millimeters of mercury, respiration 20 cycles per minute, temperature 36. There were no obvious abnormalities seen. So I can't see that right. Okay, so it was commenced on ART on 26 May 2017. Then later on switched to TLD on 22nd March 2019. Then when you look at the tests which were done, of course the HIV test was done on the 26th of April 2017, which came out positive, and then he was initiated on treatment. Then viral load, the first viral load was collected on 27th February 2018 and received the results on 30th June 2018. The results were less than 20 copies per mil. Then the second viral load was on 22nd of January 2019. Later, then the results were received on the 22nd March of 2019. The results were 21 copies per mil. Then when we received the second viral load, we transitioned the client to TLD, and then he was also commenced on IPT, that is isoniazide, and then we also gave him B6. On 27th of February 2018 was collected. Then on the 9th March 2018, we received the results, which were 342 cells per millimoles. RPR was not done, creatinine was not done, ALT was 42.5, AST was 43.5, HB was 15.1 grams per deciliter. Then of course, sputum was collected on the same day, which was the 28th of April 2017, which came out positive, and the client was initiated on TB treatment. Then after the client finished the TB treatment, sputum was collected again, and then we received the results on the 18th of October 2017, which showed that the sputum result was negative. Next slide. So, since our client is on, is a stable client, and then he's also on INH. So how do we maintain DSD and INH collection for this patient?
Okay, thank you very much, Mutinta. And I think this question was also posed earlier by Memory, so I think it will be answered together as we discuss. So who's gonna go first in the comments? Howard University?
Yeah, we can go. The team is available.
Okay, so maybe just to recap for the case, this is a 42-year-old man who was diagnosed with HIV in April 2017. At the time, I think he presented with TB. So he is married, the wife with 2 children who are all HIV negative. He received 6 months of TB treatment, of which sputum became negative. ART was started a month after his diagnosis of HIV and was started on TLE. The viral load became undetectable in February 2018, which was last year. And then this year, in March, he was transitioned to TLD. He remains stable and is virally suppressed. Now, the question is that how can he be maintained on DST in light of him receiving isoniazid? And I think that's what we'll be discussing today.
Right. And I think that's very appropriate. And usually when we have a case like this, the team discusses and again, these are generally guidelines that we have, and sometimes we have to put in clinical judgment because there are some specificities that are a little bit different, and some of them we individualize care in certain cases. So the question is, which the team, it was at Matero, Kanyama, Chilenje, or wherever they are working, I think all of them agree that this is a DSD patient. And the question that we had been debating was, if it's a DSD patient, the convenience that you want to give a DSD patient is that you have 6 months worth of medication. You don't have to be coming back. But based on the guidelines that we have, because of IPT, it may require that the patient comes back a number of times. So the question to the frontline group, which I'm sure we've dealt with this a number of times, how do we manage the case? Tamara, and then after that, Rodrigue and Mary and Bachi could say something.
As you correctly put it, this is a DSD client. And they have the HIV, and they have the 6-month supply of the ARV. And then you're giving them the IPT and telling them this is for prophylaxis, and you're giving it for a month. That alone, because they don't have the TB yet, that alone might hinder adherence on IPT. So I think for a DSD client who's on IPT, you need to consider the number of times they come to the facility. And if you have a system in place where you can monitor them out of the facility, for instance, what we do in terms of calling them to check up on them every 2 months, I think you can still go ahead and give the 6 months. Otherwise, they will not come back after a month or after 2 weeks because they already have the ARVs. So subject to debate.
Can I just do a quick follow-up and then I think that will come. In terms of that, the patient just completed treatment for TB. So, Rodrigue, should this patient actually be getting prophylaxis or preventive treatment because they just completed TB treatment?
They completed 2 years.
Oh, was it 2 years? 2 years? Oh, it was 2 years. Okay. Okay, no, it was 2 years.
Even when you just completed, you can right after that you start.
Well, even when you just completed, that becomes an individual situation where you are assessing the case for potential relapse. Otherwise, isoniazid is known to, and I'm sure a lot of people in the room here would know, it has after 6 months of preventive therapy, it has a protective effect. Some people think it's 2 years, some people think it's 3 years, and I think what is adopted in Zambia is 3 years. Some countries are actually adopting 5 years even, because that's what some of the studies are saying. I think I'm very comfortable with 3 years. I would even, 2 to 3 years. But again, you have to be able to look at the case and look at, is it a potential case for relapse and things like that. So that's one of the things. But the patient has just been switched to TLD. If you were getting a patient that has recently been switched to TLD, how do you manage it, Mbachi, in terms of what we know were the guidelines for switching TLE to TLD? Is this patient also going to get 6 months worth of therapy? I think those are some of the questions that we'll be asking and discussing within the group. Machi.
Again, there are a number of things that we need to consider because right now we, of course, there's a recommendation that we dispense for 6 months. But in a situation where you transition someone from TLE to TLD, of course, from inception, we're advised to dispense just for a month and then follow up consecutive months. But the practice right now is that you give for 3 months. I think the concern could be because they're just transitioning from TLE to TLD, the change from efavirenz to dolutegravir may come with some ADRs that you may need to monitor. But again, knowing very well that dolutegravir comes with a much lesser risk for ADRs, you can comfortably give for 3 months, of course, monitor.
You want to add?
Well, I think we discussed at one of the sessions we had in terms of transition to dolutegravir, the guidance, what's recommended from the public health point of view across the program. Of course, as you said, you can't give 6 months to dolutegravir right after transitioning. So I think that the consensus and the agreement, my understanding, unless it has changed in the meantime, but the consensus to apply it across the programs and the organizations and across the HIV program nationwide is to give for 1 month, then to give for the patient to come back at 3 months, and then 3 months. So 1 month, 3 months, 6 months. And then you can start giving for 6 months if there are no issues, no side effects, adherence reported issues. So that's one way to avoid the situation where you're asked to give 6 months.
Can I just do a follow-up with her? Because she's from the Ministry of Health. So those ones that we've switched so far, do we have any aggregate information on the adverse drug reactions? Are people actually documenting, monitoring it, and sending you the information so that you can see how many of them actually have documented any adverse drug reactions?
That's a very good question because I know I got a call from Chawama where they had seen some gynecomastia. So we asked them to document, but they didn't have the pharmacovigilance forms. I know we did a session on pharmacovigilance, but just looking at the way the things were answered, it's very clear we are probably even underreporting certain things because we know the some countries are showing something about weight gain, especially in people who are already obese. But we know our population is not generally obese, so we don't know what we are seeing. But of course, we've had some people having difficulty sleeping, but whether they've documented, I would have to get back to pharmacy department. But now to get back to this case, I really like your observation. Like this patient doesn't need IPT for now because our Zambian guideline is 3 years in between. So for now, they are not due. But it's a very good question because this is what now we are saying. Everybody should be on IPT if it's your first time on ART. So how do we integrate this with DSD? Speaking to the NTP program, because we have guidelines, they said they want to see a patient at 2 weeks, at 2 months, and 6 months. Because IPT, for now we're using isoniazid, it's only 6 months. Then you can fall back into your routine. So you have 2 inconvenient visits. I would not recommend giving somebody INH for 6 months without being seen because of the toxicity that can come with INH. At least the 2 weeks you need to see the patient. So we'd risk missing toxicity if we give someone INH for 6 months because we don't know, because some of the reactions are idiosyncratic, isn't it, with INH? So you can't just hand out INH and say go for 6 months. I think that one we should be against our guideline because our guidelines is 2 weeks, 2 months, 6 months. I think we need to stick to that. But the good news is this patient, by the time they need IPT, TPT, will have rifampicin with isoniazid, which is only 3 months. So it's even much, much shorter. So it should inconvenience DSD even way less. And I know there are studies that are now showing, proven, that you can even just give TPT for a month, which is rifampicin and isoniazid. But for now, Ministry of Health has not adopted that one because we've ordered for where you can take a week for 12 doses. So in future, we expect this to really not impact DSD.
But beyond, I can add, beyond this case, in general, if you have a patient who is on ARVs for 3 or 4 years, they have never been on TB treatment, and now they find themselves, they are eligible for IPT, for TPT. So I think that the question is now how to harmonize the scheduling of the dispensation in a way that you don't harm the two interventions, the IPT expected benefits and the DSD purpose, in a way that you can give them at the same time. So that's where we need a firm and clear recommendation for the HIV program across the board, so things can be applicable the same way. Because as you said, 2 weeks, 2 months, 6 months, but then it's 1, 3. So that's the expectation, I think, from the field, is we have to be on the same page. We have to have a good a way to harmonize integrate the two recommendations between HIV and TB program. And I hope in a couple of weeks, when we have maybe the next session, we'll have a clear answer to that concern from the field.
Okay, so thank you very much. I think there's a concern from Chilenge. This question is about how many viral loads do you need for you to enter in the DST? Or basically, how many viral loads should one have for one to be labeled a stable patient? Dr. Ahmed?
Yeah, so that was one comment I had. The slide 12 you presented, that's absolutely 100% perfect, and it's correct. It just, we had to address some questions, clarification questions based on that same kind of algorithm. That's based on the guidelines, national ART guidelines, and we had sessions specifically to address that. So you don't need to wait for example, if you're on ARVs for 3 years, you have a suppressed viral load today at 3 years on ARVs. You don't have to wait 1 year again to have 2 consecutive viral load suppressed. That day you can already switch to either TLD or
that's what the team does.
Yes.
That's what they do.
So what's meant on the slide, what people saw on the slide, that means that's in relation to new patients starting ARVs. If you can, ideally 6 months and 12 months after ART initiation. But even if you don't manage to do a viral load at 6 months, if you have a suppressed viral load at 12 months or 13 months, you already can switch to DSD, you already can transition to TL. So that was something that was in a way hindering the implementation of viral load testing, routine testing, and transition to transition to TLD, transition to DSD. But I guess now, I hope that at least 95% of those who attend these sessions, they already understood that we don't need 2 viral loads suppressed if you're already past 12 months on ARVs. You only need 1 suppressed viral load result to decide.
Let me simply say that for those clients who are on ART for less than a year, all they're the ones who need maybe 2 viral loads. But if you have been on ART for 1 year and you are suppressed, there's no need to wait for the second one.
If you've been on ARVs for less than a year, you need to wait until you get
2 viral
on ARVs for a year. You do viral load. If that's your first viral load you're doing and it's suppressed, you switch. You do transition to DSD and TLD. But for DSD, you need to wait 12 months on ARVs. For TLD, you need to wait 6 months. That's what the national agreement consensus based on the technical working group that we discussed at the session.
So DSD 1 year, TLD 6 months.
6 months.
All right, great. And I think this is very clear with Chilenge. There's another question, I think, asking about the interval for isoniazid. Will it be monthly? I think
2 weeks,
we shared
6 months, 6 months. And we will stick to that because I see no harmonization. There are different drugs that work very differently. I think it would be very unwise for us to advise people to say give it for 6 months. For now, we are saying no. We have seen toxicity in the clinical setting, and it's very unpleasant. It's only 6 months, and we are moving to 3 months. So this question.
No, and we're sure that the agreements between the 2 programs, as I understand it, is that we're not going to give 6 months isoniazid. So that's for sure. So what we know now is that guidance from TB program perspective is at 2 weeks, you give for 2 weeks, then you give up to 2 months, and then you give the rest, 4 months until you complete 6 months.
So it's not monthly?
No.
It's not monthly. So you give for 2 weeks,
yes.
Clients come back, give them for 2 months, they come back to check for intoxicities, then you complete for 4 months.
In the meantime, we will work on getting a clear and precise answer that addresses the harmonization between DSD, patients who are eligible for IPT, but they are coming for ARVs for 6 months, but they need to take IPT. So that we need to work on harmonizing the scheduling, whether it's going to remain the same or...
So there's another question, Dr. Somba. I'll put you on the spot on this one. And I think it's because people are asking the same question. A patient who has completed TB treatment, how long should they wait for them to receive IPT?
So there are two schools of thought. Actually, the WHO recommends for pediatrics, if you finish your TB treatment, you need to take INH just after that. Right. Even for adults. But we all know on the ground that this is not happening, because even just for INH, people are not completing these doses. But ideally, they should go on. But for us, we are taking 3 years in between. That's the maximum we can allow between 2 intervals.
So our patient for today was at which is 2 years ago. So meaning we only expected them to do IPT next year, isn't it? All right. And I think we've tackled the question both of, did this patient qualify, and how often should they be reviewed if they start on IPT, even when they are in DST? Can I have some more questions?
But I like what Tamara said, that we need to be considering how we can harmonize, like maybe a home visit is enough for 2 weeks. If you're on INH, if you are visiting for something else, we ask, do you have any side effects? You don't know if you are vomiting, feeling weak. There are those classic signs of INH toxicity. And that way you may harmonize your community DSTs with INH. But it's something that's up for discussion. I know a lot of countries are looking into DSTs for TB patients.
So what if the client say, at 2 weeks, can somebody just come home? Or should we stop them and say, no, you have to come back?
I can't say that. That is why Ahmed is saying we need to have...
That's one way of doing DSD. It's a patient-centered service that you can deliver. So it's up to the program to innovate and see how they can meet the needs of those categories.
So if the facility is capable.
Yes, and I think actually there is a project, there is a pilot project here that's being led by the Ministry of Health in terms of finding other ways of provision of IPT, including in the community, avoiding that patients will come back to the facility each time. So assessing adherence, providing IPT in combination with other services within the community. So that's something that the Ministry of Health is leading.
Chand, is that? Can see. Nathan. Okay, Nathan, your hand is up. Would you please go ahead and ask your question or make your contribution?
Thank you very much. Mine is a question, and it's with regard to the targets for DSD. If I remember very well, the target should be 80%. That is for facilities that have got a TX score of more than 3,000. Now, my question was, what about these other facilities that have got patients that have got a TX score of less than 3,000? What's their target for DSD? And then does the 80% target only apply to maybe one form of DSD, or does it apply to all these other forms of DSD? Do you have to add the multi-month scripting, the urban adherence group, then you come up with 80%, or it only applies to one form of DSD? Thank you so much.
I'm not sure. Did you get the question?
Yeah. So I think it's the same target to be simple and harmonize everything. Regardless of the volume of the patients at the site, you need to be aiming for having at least 80% of your stable patients with evidence that they are stable, who are enrolled in one way or another in a model that's a DSD. That's regardless of which kind of DSD it is. So it includes CADs, it includes fast track, it includes multi-month dispensation. Whatever is proven to be called DSD is considered as DSD. and is supposed to be covered by 80% of those who are stable on ARVs.
And another concern, just before you leave, if say a patient has been stable on ART for 5 years, then we change to TLD, all right? Or previously they were in DST, and then we change to TLD. What should be the appointment scheduling be like in a patient who has already been in DST?
So that's what we touched on a few minutes ago. My understanding, based on the discussions we had within the key people with the technical working group and IPs and Ministry of Health, is that you give for 1 month, you ask the patient to come back at 1 month, at 3 months, and then they will complete their follow-up 6 months, and then they will start coming every 6 months.
Okay.
That's my understanding so far. That's why I said we need to provide a clear recommendation at the next session that addresses not only the DSD, the transition to TLD, but also IPT.
Okay, great.
Yeah, I just want to quickly add something to Nathan's question. Was actually an operational question. One of the things that he was trying to find out is that if you have TX score of less than 3,000, I think the reason why people are going for a higher TX score is because the congestion there is much, much higher, and operationally and practically they can't do all. Otherwise, every and each patient is very important. I think it's just because of practicality. But the other question which Ahmed has answered very well is that the DSD model, it doesn't matter what the DSD model is. But I will also beg to say in the future, we need to be able to just compare the DSD models to make sure that we're getting the optimal results out of it. And so that's something that in the future, probably we need to just look at it to make sure that we're getting the maximum benefit. Yeah.
So Challenge is also concerned that this is actually not in the memo or something like that. Is there a memo? Because they are there.
What's not in the memo?
About the scheduling, the appointments for
that's what I was mentioning. I was saying that my understanding is that the consensus so far, at least informally, is that we're not going to give 6 months of dolutegravir when you transition. The suggestion was from many people from technical working group is that we give at 1 month, 3 months.
When is this memo coming? I think
I don't say. That's not for
okay. Okay. I think this is for Dr. Foloshi. I think that's where the concern is. So because this information in several sessions we have had it and we have discussed. Now people, what is not written. It's very difficult.
It's a fair concern, and that's why we have these sessions. Remember that we're a network. It's a back and forth. Sometimes you learn from the people on the ground. Sometimes from this end. I know we did have an echo session with them. Infectious disease director, Professor Boyd, and he's one of those guidelines. And that's why we'll be issuing another memo to that effect, because there will be some confusion and how we're going to make them. Because we'll be looking at the guidelines again. We now know that who is saying TLD is your preferred first line. So how do we approach it for women? So we're putting all these ideas that we're getting from the network so that we come up with something more comprehensive. But you're very right.
Yeah, and hopefully very soon there will be something that addresses not only that DSD part for IPT, because that's it's
very closely related.
There are more people eligible for IPT who are already on ARVs for a long time than the new ones. Yeah. So you need to address that very quickly to make sure you're not harming your DSD and you're not taking out the benefits of IPT.
Okay, so thank you very much. I don't know if there are any concerns from the network. If there is any burning issue, kindly let us know before we conclude.
Hello?
Yes.
Yeah, our concern is that this client from 2017 up to date doesn't have any results for creatinine, and we don't know the creatinine clearance. So can we continue pushing this client for 6 months? What if we don't know the creatinine clearance? Because it might end up, by the time he's coming for 6 months, the kidneys are knocked down because we don't know the creatinine clearance.
Okay, so I'll give that to Dr. Foloshi. What's your comment about
in terms of
playing around with all these drugs without creatinine?
If you look at the criteria that Professor Fomundam put up, we don't talk about things like creatinine. But I must mention, for differentiated service delivery, there is the unstable client and there is the stable client. Mm-hmm. And ideally, you should have a creatinine that tells you the patient does not have chronic kidney disease.
Right.
So that's something like if I'm putting someone in the DSD, I need to make sure they don't have mental illness, they don't have comorbidities, which could include something like kidney disease, and that's very important. And we do acknowledge we do have some lab challenges on the ground. And this patient by now should have had the creatinine. And I don't know if I'm the best person to answer it, or maybe the facility. I know we have a bill. So does the patient have a creatinine?
I know it was our concern as well when it was collected, but I saw the urea was 3.6. Yeah, the last urea, but we didn't find the creatinine.
So the facility, I think, attempted to follow up on that one, because you have to make sure there are no comorbidities such as CKD if you are putting them in a stable model for differentiated service.
So before we end, I have one just comment to make. I think the presentation is great. This is to emphasize again what people heard about DSD. I'd like just to add, to take into account what was mentioned in the presentation in terms of having a sound system for scheduling appointments. That's, I think, the one key element of successful implementation of DSD. And I think I'm just emphasizing that, knowing that a lot of sites don't have a proper systematic scheduling, giving appointments in a systematic way using SOPs. I think that's one key element for sites to work on a system that works for them to give appointments based on what you recommended, as with number of patients per day or duration by visits, by clinicians. So that needs to be put in place to make sure that any DSD intervention that's implemented is really successful. And that's what we noticed is missing for many sites, especially high volume sites.
And maybe we should congratulate Howard University again, because we need to be cognizant of our culture. We are coming from a culture where we don't do hospital appointments. You just walk in when you want. So I think also there are issues of behavioral change. I know people say the health worker must be committed. And even the patient has to be able to change their behavior, because I grew up not following appointments. Now you're telling me about appointments. I think that's also something.
Are you following now?
Yes, I have to. Because also our culture is not one where we really follow appointments. We never use this system, so it's something that's new. So we are saying congratulations, well done. We have a lot to learn from material.
Thank you.
Behavior change is one difficult thing.
So one last thing from Lewanika. Lewanika, can you go ahead with your contribution or question?
Okay, thank you very much. It's just not really a question, but one to learn from Matero. Well, we are facing a little bit of challenge, like knowing when you enroll clients on DSD, you find that for continuity, like if someone is on NMS or fast track, the next visit that they'll come, there's no harmonization on continuity of the same DSD model. So I want to know if they had put something in place like a card to really identify a client on a certain DSD model.
It's about location.
Yes, indeed. So we have a card. It's not very different from the regular care cards, but this is a card. It's a care card. It says differentiated service delivery right at the top. So this card is a little bit modified from the regular card that you see, because it also has a column for time in the back. So immediately this person gets into the facility, when they go to the registry department, the first point in the hospital, already the person in the registry knows that this person is DSD. And without even wasting time on the queue, on the main ART queue, this person will be sent straight to the DSD clinic. So we do have a card, yes. And this helps, firstly, the client to know where to go, and also the person in the registry who's directing clients to be able to tell them where to go.
I think a question is on the models.
The model.
If I come, I'm in a multi-mark scripting, or if I'm in a fast-track model, sometimes they are finding patients are switching. Today you're in a card, tomorrow you're in a UAC. How do you maintain that same model? Is that question.
So the very card states to say fast-track, DSD fast-track, or DSD down referral site. There's even the site there. If this client picks up from a health post, the health post is written on the card. So it has a provision for the name of the model.
Mary just wanted to say something.
is that you prescribe 6 months worth of ARVs to anyone who is stable, which is the majority, we hope.
Yes.
At least 80, 90% of the cohorts. So at some point, when you transition everyone who is stable to 6 months, you'll have most of your cohorts, your normal cohort scheduling will be the 6 months. So the fast track will be becoming the normal practice. The fast track used to be, especially at Mateo, 3 months, because you don't want to make people wait, so you give them, it's kind of a very quick visit to make sure that people don't wait a long time because they're already stable, they have their viral load. But now, most of patients will be on 6 months ARV prescription. See what I mean? So at some point, it's going to be obsolete to have a fast track that gives 3 months. The fast, maybe have post, yeah.
So, Dr. Ahmed, actually, what we have right now in our facilities is a full-fledged fast track clinic.
Yeah, so that's what your clinic is going to become.
Yes.
That's what your normal clinic is.
Will become that, exactly.
It's not a fast track anymore.
Yes.
It's your normal clinic. Based on the national recommendations of, because 6 months used to be DSD, but now it's not DSD, now it's the normal practice. Whoever is stable needs to be in 6 months.
Exactly.
So that's how we need to understand it also.
Dr. Zam.
Yeah, so in response to the Wanika Generals, also, the other thing that you also need to look at, even as you are arranging, is the way you've arranged and structured your ART department, and the way you've arranged it. It also helps once you organize it in such a way that patients know where they're supposed to be, and even the staff know where certain patients are supposed to be. And I think this is an example that even in Uganda they're doing. They actually, the whole care in terms of HIV care in Uganda is actually, you would actually call it a whole DST because of the way they've arranged and organized their kind of care. And so I think even in Zambia, we really have to help ourselves and our clients. We would have to restructure the way we have been offering care. And it will have to be aligned to what we want to achieve. And so we need to change a few things. And so you could start off with that as Lewanika. And I think Howard has a very good example and a template of how you can actually have those things changed.
All right, so thank you very much. And I think Leonard has just shared something from Namibia, and the experience from there is that community-based DSTs actually assist well with reducing congestion, whereas fast track and MMS will basically just reduce the patient waiting time. So this actually ties in with the earlier concern about the difference between congestion, which is more of space, and delayed time. And I think we have had a good discussion today. So as of the case Mutinta and the group, definitely we shall write the recommendation for this patient. But as for now, this patient, we say that does not qualify for INH because they last took TB treatment within 3 years. But I'm sure, as Dr. Sombo said, we should be having rifampicin and isoniazid soon, which will somehow change things in the future. So thank you very much. I want to thank our members from Howard University who are doing tremendous work at Matero, and I hope that we can learn a lot from Matero experience. I want to thank, I know the team is quite big, they're about 5, Tamara, Mary, Mbachi, Rodrigue, I've forgotten one name. Dixon, all right. Dixon was unusually quiet. Maybe that's why. And Bill coming all the way from Petauke, where the case is coming from. I want to thank everyone who tuned in the network and remained all the way up to the end. The next ECHO session will be on the 12th. So kindly note that next week we won't have any because it's a holiday. And we shall be continue discussing the actually isoniazid prophylaxis or preventive therapy. So this discussion actually continues next week. See you next week. Now, see you after next week. Goodbye.
Thank you.